This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you. Good afternoon, everyone. And I would like to first thank the organizer, particularly Daryl, for giving me this opportunity to deliver this talk today. So I have no, I don't know, where's this? Sorry. I have no conflicts to declare. And I come from Canberra, as I was said, and it's a beautiful, colorful city, and we are quite passionate about rapid response systems. So in my talk, I'll be defining what clinical deterioration is, why it is important to detect it early, and how rapid response system actually helps in doing and achieving this target. And I'll be talking about and answering these questions in an evidence-based fashion. So to begin with, what is clinical deterioration? So until 2013, there was no particular uniform definition used in literature until 4 guys from Australia, including Daryl, Ken, Imogen, and David actually sat down and published this article. They defined clinical deterioration as when a patient actually moves from one clinical state to a worse clinical state, which actually increases their risk for not only morbidity but also mortality, and this can happen whether they are in a community or when they present to ED during the hospital or the ward stay or when they are in ICU. And one of the primary goals of healthcare is to try and reverse this deterioration and try and bring and send them back to the community. So in a hospital patient, clinical deterioration can relate to the presenting complaint they originally came with, or a new problem that has developed during the hospital stay, or as a complication of the treatment or the care that's provided during the hospital stay. And if this is not attended upon promptly, this often results, as I said, in mortality and morbidity. So this is one of my favorite slides. So it actually depicts what clinical deterioration can be, and any patient that gets admitted to the hospital, gets routine hospital care, and gets better and returns home or is discharged home with the same pre-morbid function, if not better, than what he had got admitted with. But there are certain patients who deteriorate, have a clinical deterioration, and if these patients actually are picked early, we are actually managed to send them home, but with more or less the same pre-morbid function that they came with. But there are certain patients, unfortunate patients, who continue to deteriorate, develop multi-organ dysfunction. Few of these actually go ahead and actually develop cardiac arrest. If the rapid response system acts fast, they do salvage very few of these patients, but these patients, when they are discharged home, they don't have the same pre-morbid function, have significant morbidity along with them. And few patients, of course, we can't save them. So how good were we detecting this patient, good at detecting deteriorations? In the 90s, we were very bad. 84% of the intra-hospital cardiac arrest were potentially avoidable. These numbers, thankfully, is coming down. And in a recent study from Victoria, it said somewhere about 14 to 20%. The other interesting study that I wanted to mention is 1 in 5 patients in the ward actually develop abnormal vital signs. In about 50% of these patients, about the staffs are unaware whether these signs are getting abnormal. And again, as I said, if these patients continue to deteriorate, they often develop multi-organ dysfunction and there's significant associated mortality. So the best treatment for multi-organ dysfunction or multi-organ failure is prevention. And we know that the impact of organ dysfunction is not just short-term, but has a long-term impact as well, as long as 5 years, if not less. We also know that the baseline population in Australia and New Zealand is at risk. 1 in 3 patients are at risk of developing kidney diseases, and if these patients who get admitted in the hospitals are not treated promptly, have a risk of actually developing end-stage renal disease, and there's a significant cost associated with it, managing such patients. So early intervention is the key, and rapid response system does have a big role to play. So what is the evidence that the rapid response has made the difference? So there's a lack of good high quality studies which is there in literature. Most of the studies or most of the data come from observational studies or meta-analysis. And most of the studies that have been published, they looked at the intra-hospital cardiac arrest rates, they look at the hospital mortality, and they have looked at need for ICU admission. So I'll be talking about a few of these studies. So what about intra-hospital cardiac arrest rates? So there are two meta-analyses published this year, and one of them was published last month itself. And what they've showed is that a rapid response system has definitely decreased the incidence of intra-hospital cardiac arrest rates, and few studies have reported more than 50% drop in their rates. And this, if you look at the other meta-analysis, also looked at the higher quality studies, and this effect was still maintained and was still statistically significant. So what about hospital mortality? Hospital mortality is considered as a key marker of any hospital safety quality, hospital-wide safety quality initiative. And again, contrary to the early meta-analysis which was published, which showed there was not much difference in the drop in the hospital mortality, the recent two meta-analyses show that there is significant drop in the hospital mortality. Again, this changes maybe because of change in the hospital practice over the period of outcome, and maybe the rapid response system is finding its teeth in the various hospitals where this study was done. And this is again, when you look at the good trials or the stronger trials, again this effect was maintained. So we can ask these questions in a different way as well. So we can ask, is delayed med associated with worse outcome? And again, there's a problem with the definition. Various studies have defined delayed meds quite differently. They have used a different definition. So the first data that I would like to present is from the MERIT study. So they looked at the MERIT data again, and they have looked in how many patients had the delayed meds. They defined the delayed meds as more than 15 minutes. There were about 30% delayed meds in that study. And I would like to thank Professor Chen to actually be able for allowing me to share his slides. And what we find is that if you are in the rural hospitals, they are more likely to have delayed meds. If they are in certain locations in the hospital are quite at culprit at denoting withdrawals quite late, and CC is quite common of them. The other thing that is quite common that they found in the MERIT study was during after hours, there was quite a significant amount of med calls where after hours, and these indirectly had quite a significant impact not only on ICU admission but also on mortality. So if you were in RRT hospitals and you have a delayed med, your mortality was somewhere about 39% compared to that of 29% in an RRT hospital. But if you are in a non-RRT hospital, so mostly in a peripheral hospitals, and if you have a delayed med, the mortality was as high as 60%, which is quite significantly high. So there is quite a bit of a problem. So this is another interesting study which not only demonstrated that the delayed med were associated with worse outcome, but all they showed was that even you have a one med criteria which was, or you have two med criteria, the mortality did not change. Or if you have a med delayed more than 8 hours or 3 hours, it didn't change. And this was again demonstrated by a fantastic study where they looked at different time intervals and their mortality. And what they looked at, as more you delay the med, the worse the survival. So the mortality actually went down from mortality actually went up from 45% to nearly 75% if there was a significant delay in the med calls. And it's partly also the problem of after hours is we don't even do the basics right. So we often also, there's a delay in basic stuff like giving timely defibrillation. And we know that each minute that goes by, there's a significant chance that you will, the success will reduce significantly, by 10%. So again, there are studies which has demonstrated after hours, we don't even defibrillate patients in a timely fashion. So we can again ask the same question in a different way, which does timely med calls actually help in improving outcome? And there's a fantastic study done by researchers from Sydney, and what they've looked at is every 10% proportional of increase early med calls or timely med calls, you can decrease your cardiac arrest rates by two over 10,000 admissions, and also the unexpected mortality by 0.94 over 10,000 admissions, so which is quite significant. So what are the barriers of effectiveness? We know that to a MEDCAL or a rapid response systems to be effective, you need to have an effective efferent arm which not only detects an active deterioration but alerts the rapid response team in a timely fashion, and we should have a rapid response team which is response not only in a timely fashion but also is well trained and well equipped. And so we've gone through the efferent limb problems in the earlier session this afternoon, but again the main problem lies the monitoring frequency. Classically we monitor the patients every 4 hours and they are monitored or they are looked at about for 5 to 10 seconds. This leaves them unmonitored for nearly 96% of the time they stay in the ward, so that's quite significant. And they can be failure to observe vital signs. Even if they are monitored at 4-hourly interval, not all obs are taken. There is a failure to activate meds. There is also significant, even if they call for help, often the system support is by the juniors from the hospitals, and there is also quite a bit of a variance in MEDCAL criteria as well used in different centers. And we currently have a one-size-fits-all criteria, where a MED criteria or a calling criteria. So this is quite an interesting paper actually, where they looked at the MEDs, they looked at the vital signs 4 hours before the arrest in patients who arrested less than 65 years old and more than 65 years of age, so the elderly versus non-elderly. And they looked at what they found was the elderly patients had a much lower Muse criteria when before they had actually arrested. They had much lower heart rate, they had much lower diastolic blood pressure, they have much higher pulse pressure index, and this is quite a significant factor as well. And if you look at the area under the curve, as you grow older, the area of the curve to actually detect an intra-hospital cardiac arrest actually goes down from somewhere about 0.78 to somewhere nearly about 0.6 or something. So it's quite a significant worsening in the sensitivity of this. So what about the barriers in the efferent arm? And the main thing is the delay in the response. The delay in the response can be because there are multiple current meds going on in the hospital, and you have to then send the junior most team, which again needs quite a bit of coordination as well. So there is also poor team communication or composition, and often with concurrent meds, this what happens is the fifth med that you go to, there's the junior most person in the ICU that actually goes to and responds to this meds. There's also a escalation of the care when the ICU is full. There's a lot of exit block. You don't actually escalate care quite in a timely fashion, and there are a lot of communication issues. And I said the issue of multiple meds and alarm fatigue. So there is quite a significant problem there as well. So where can we improve from here? I think the main problem is our whole med system is at risk, and it's a risk of breakdown, because again, what we've shown is that in few centers there is about 700% rise in the proportion of med calls since they have implemented the program, and with the multiple meds happening concurrently, there's quite a significant alarm fatigue, and we need to do something for it. So one way that we have heard is to use of technology, where we can use which can help in actually maintaining or monitoring continuous physiological parameters, or maybe identifying the patients at risk and cohorting these patients and monitoring them a bit more closely. So you need to have a separate arm in addition to the detection. Maybe we need to predict the risk and maybe actually be able to cohort this patient and monitor them so closely so that these patients require less and less help from ICU. So for example, you can use simple scores like SOFA scores at admission. If you look at the SOFA scores at admission to the hospital and their outcome, the higher the SOFA score at admission to ED, this is a SOFA score taken in ED when they presented and they looked at the outcome. And if you see if the patient has a high SOFA score when they present to the hospital, the chance of mortality is much, much higher, and you can use simple scores like this in actually cohorting these patients and monitoring them a bit more closely. We can even look at the Muse criteria where if the Muse is at above 4 when they present to the ED, again they have higher risk of actually dying dying, they have a high risk of getting admission to the ICU, and so you can use simple things, if not the complex things. So I look in the future, rapid response teams should be taken as a matrix where it's not only dependent on the efferent arm, not much burden is given on the efferent arm or the efferent arm, but it's a group as a matrix. It's looked at a matrix in actually trying to save patients and detecting deterioration a bit early. So my take-home messages are: we need to identify patients at high risk of deterioration and consider monitoring them a bit more closely, detect the deterioration more accurately using evidence-based tools, and actually integrate integrate detection into continuous physiological monitoring, as Michael was talking about, and eliminate the barriers in both the efferent and the efferent arms. I would like to finish with this quote: the greatest opportunity to improve outcomes in patients over the next quarter of the century is probably not by discovering new treatments, but from learning how to deliver the existing one more effectively. Thank you.